Welcome to Joint Effort with Des Moines Orthopaedic Surgeons. This podcast covers the pain and injuries that are associated with muscles, ligaments, and joints.
I'm Barron Bremner, and today on Joint Effort, I'll talk to Joey Brunkhorst, expert in sports medicine, about cartilage damage and cartilage repair. You have an interesting background in your training, including doing D1 sports and also armed forces, true?
That's correct.
Can you tell us kind of where you grew up and you know, where you came from?
Yeah, so I grew up in Iowa Falls, north central Iowa, small town. Played 4 sports a year there. And then after that, I went to Iowa State, and that's where I was on the track team. I high jumped on the track team, and then after Iowa State, I went to med school. And then after med school, my internship was in the Army. I signed up for the Health Promotion Scholarship Program.
Okay.
And so they paid for my schooling for the med school.
Did you have people in your family that were in the armed forces too?
I had
no?
an uncle and some cousins.
Okay.
So a few people, not a lot,
Mm-hmm.
but it was always something that kind of interested me. Up to that point, I didn't really have the opportunity with the track and other stuff going on. So I signed up during med school, and then after med school, after I graduated, I did my internship in the Army. And after my internship, it was 3 years as general medical officer. And
Did you get to travel like overseas or just
I did.
domestic?
So I was stationed. My internship was I was stationed in Augusta, Georgia, Fort Gordon, and then I went to Lower Alabama, Dothan area. It's Fort Rucker. It's the home of Army Aviation, where where all the helicopter pilots train. And so I did a flight surgeon course there. It's just a 6 week long course to kind of help learn how to take care of pilots and just the abnormal atmosphere that they're in, or abnormal environment that they're in. But along with that, I was able to do, I didn't actually fly the helicopters, but I went up with them and got flight pay, which was fun, good experience. So I was there for 3 years, but the middle year, I was deployed to Iraq with the 25th ID, the Infantry Division, out of Schofield Barracks in Hawaii. So I was deployed to Samarra, Iraq for 12 months.
What years were those that you were in the military?
It was the military from 06 to 2010, deployed from in 08, 09 area.
And now are you like kind of on call for them if something happened?
So when you sign up, you pretty much always sign up for 8 years. So I did 4 years of active, then 4 years of IRR. It's Individual Readiness Reserve. Okay. And the IRR, you don't really have to do the weekend once a month or the 2 weeks a year. It's just you're on a list somewhere. It's like the last thing before a draft. So they would so during those 4 years they would draft me before they draft you type of thing. And then after my 4 years of that, I just resigned my commission just to prevent that threat of deployment. Sure. So,
and you and your family are now living in Ankeny?
We are.
Okay. Yep. And how many kids do you have?
2 girls. One just turned 10 yesterday, and then the other one is 7.
What do you think about the, you know, there's a new-ish relative to our other buildings, but we have a new DMOS building up there. When did that go in? What do you think about that? What has it got to offer up there?
That went in about 3 years ago, and that's when we had our groundbreaking ceremony, I think in May of that year. It's a really nice facility. There's 4 pods, but we have plenty of room for a number of surgeons there. So right now we have pretty much every specialty within orthopedics, or the main specialties covered. So sports with me, foot and ankle, joints, spine, hand. And we also have a physical therapy department, an MRI machine, x-ray. So we have pretty much everything we need up there.
And urgent care too,
and
correct?
Urgent care clinic that we started about over a year ago. And then we're just expanded this month.
A lot of the sports surgeries and things that you do, are people go home the same day. Can you do them up there near our office, or where do you put those surgeries?
Yes, so next door, or just down the street, within 200 yards, is the UniPoint Medical Park, right on 36th and Ankeny Boulevard, so just on the north side of town there. Within that Ankeny Medical Park is the surgery center. So in that surgery center, that's where I do most of my surgeries. I'm there every Tuesday, every Friday, and so it's really handy. Okay.
Well, let's get into the meat of the topic here and talk about cartilage. You know, we walk easily more than 5 million steps a year, and you know, how do our knees handle this? And you know, what is cartilage and that sort of thing? You know.
Yeah. So cartilage is kind of that. Sometimes I describe it as like that shiny stuff on the end of a chicken bone that people see. It allows for nice, smooth articulation in any joint. As when that starts to break down, that's when you have arthritis. When you start to lose that cartilage, that's arthritis. And there's
what's the difference between arthritis and like injuries to the cartilage, things like that? You know,
I guess the injuries, sometimes the injuries are kind of, I mean, in a way can kind of consider early arthritis, but there are certain times when younger people have a specific injury to a piece of cartilage where it breaks off. There's different reasons for that. Sometimes it's like a direct blow to the cartilage, and that piece will break off, and that requires, you know, surgery. Otherwise, you know, you have arthritis because that cartilage is missing.
Maybe before we go on to talk about treatment of this, is there anything that people can do? Like a supplement or some kind of lifestyle choices that they can make to keep healthy cartilage? Is there any evidence that shows that any of that stuff is helpful?
Well, so yeah, there's different factors go into arthritis, right? So one of the biggest things is genetics. You can't really do much with that, unfortunately. But there are things that kind of can contribute to arthritis.
Are you saying you don't like your parents? You'd like to choose
some
different?
People probably would say that, yeah.
Right.
Not me, though.
No.
But some people will have increased risk from their genetics or their parents. But then past trauma, like we talked about, you know, possible sports injury to the area can cause early arthritis. Weight can cause increased weight, can cause more pressure on that, can cause arthritis. But as far as you know, doing things as far as supplements, things like that, it's really hard to treat arthritis. And we've tried a number of things through the years, and we're still trying to, you know, come up with new things to help kind of cover that gap between where we can do, you know, surgery to help correct cartilage loss and total knee replacement. Some things we've tried in the past is like hyaluronic acid and pills, or glucosamine. Chondroitin, those pills you see over the counter, and the results aren't that great on that. And so typically in our academy, Orthopedic Academy, does not recommend those pills anymore.
What about for like a teenage kid or something? If a 17-year-old said, "Hey, I'm taking glucosamine and shark cartilage and some kind of cod liver oil supplement to protect my knee from these sports injuries," is there any evidence for anything like that works or no?
I haven't seen any, and a lot of times I'll just say, you know, if it works, that's fine as far as what they feel, but it's probably just a waste of money.
Yeah. So in addition to the cartilage that you said, the shiny cartilage on the end of the bone, there's another type of cartilage in the knee at least called the meniscus. Can you describe that?
Yeah, so the meniscus, I usually describe them as two C-shaped cartilage structures, a little bit different than the hyaline cartilage of the end of the bone, and it's a little bit softer, but it's a different type of cartilage. And the properties of that cartilage is kind of some cushioning. They act as chondroprotective, meaning they help protect the rest of the cartilage, but also provide a little bit of stability in the knee as well.
Okay. So they're kind of shock absorbers, but they also, especially in somebody who might tear a ligament or something like that, they confer some stability or restraint to the knee joint. So we talked about hyaline cartilage, which is a shiny cartilage on the end of the bone, and then we talked about fibrocartilage, which is the meniscus. And if we have time, we'll get into meniscus tears. We've already talked about them a little bit on other podcasts, but might talk about meniscal transplants or something like that. But why don't we talk about now, you know, a cartilage lesion, not an arthritis type lesion that you might just get over time, but you know, you might be a 12-year-old kid or a 21-year-old and you've had maybe a twisting injury to the knee, and now we get an MRI because your knee's swollen and there's like a piece of cartilage missing from the end of your femur bone. Does the size of that lesion matter as far as what your treatment options are?
It does. The size, as far as the area it covers, the location of that defect, and also how deep it is, all kind of factor into what needs to be done, if anything. Sometimes you might be able to treat some of those non-operatively if it's more of a non-contact area or area that doesn't see a lot of articulation. And besides the injuries, there are also lesions called OCD lesions, where just a lot of times what we're seeing is it's caused by repetitive stress or like an overuse injury. We didn't know what it was for a long time, but it seems like they usually occur in people that are very active, so it's more of an overuse type of injury. It's called an OCD, osteochondritis dissecans, and that's where a piece of cartilage, and sometimes in the bone as well, can kind of start to fall off in kind of layman's terms. And
correct me if I'm wrong, those are better prognosis if the patient's very young compared to older.
It is, yeah, because they have more growth potential.
What did you mean by the prognosis or the treatment options are different based on the location of the lesion in the knee?
So a lot of times if it's more on the very periphery of the knee, just kind of where the cartilage is starting to turn into normal bone, and it's a small lesion, it may not have much effect, and maybe you'll just treat that non-operatively. Some of those locations.
Okay. One of the initial treatments that was developed to hopefully bring new cartilage into that area is microfracture. Can you tell about the limitations with that and the benefits of that, and what it is?
Yeah, so microfracture is when you lose that cartilage, you scrape off the whatever's left and get to the calcified area, or right above the bone, and then you drill or punch some little holes in the bone. That promotes some bleeding from the bone, and then over time you develop fibrin cartilage, a different type of cartilage, which again is better than no cartilage, but it's not as good as the hyaline cartilage that you normally see. And that has some benefit. The problem with that, though, is the benefit only seems to last a few years. We don't see a long-term benefit from that. And it seems like eventually that they may need to have something else done. So it may be a good temporizing procedure at times, but it's not the best procedure. And actually, there's one class of athletes that's shown do really well with that. It's alpine skiers, but besides that, there's not a lot of great research or studies that show benefit in other people.
Can you do that on the patella too, or just on the end of the femur bone?
Nope, you can do it on the patella. It's not as, you can do it on the tibia as well. It's not as common.
Yeah. And
you need to do it if it's only like unipolar, on one side of the articular surface. If you have both the tibia and the femur, it doesn't work as well.
Yeah. Do you restrict them pretty much after that, or do you the initial treatment was put them in a CPM, non-weight bearing, 6 weeks. A CPM is a bending machine. Do you do that, or do you have a little more aggressive protocol now for that?
A little bit. I do. I think CPM machines are very good for articular cartilage as far as trying to treat these procedures.
And it's a machine you put the leg on and it bends it up and down. Okay.
Yeah. And I usually partially limit their weight bearing, but I'm a little bit more aggressive than the conservative treatment of non-weight bearing for 6 weeks.
Okay. So that hole, or I consider it a pothole, as opposed to like arthritis where it's worn down diffusely through there. But if you find a pothole in there and you're thinking about doing microfracture, is there a certain size that, in millimeters or whatever, on how big it is? If it's bigger than that, you're not going to do a microfracture, that sort of thing? Well,
I think a lot of people vary their what they do with that. I think the bigger is probably not very good. The bigger lesion is not going to respond as well. And actually, I don't do a lot of microfractures because again, the studies don't show a lot of benefit over just doing a chondroplasty where we kind of roughen up and clean off the cartilage. And it seems like they do just as well or very similar. And when we get to the point where we need to do more, there's other procedures I prefer over the microfracture.
Well, let's talk about that. Another couple of options would be harvesting some cartilage from somewhere else in the joint and with bone, or doing some kind of cartilage inlay type technique. Can you tell us about those different options?
Yeah, so there is an Oates procedure where you take cartilage from a different piece of the part of the knee.
What's that stand for, Oates?
That's osteochondral autograft transplantation.
Okay.
Or transfer, I should say. So we take a little piece of the cartilage from a different portion, again, like the non-weight bearing or the cartilage where it's not being as affected by the articular surface as much, and then put that over the lesion. So you're transferring the lesion, or transferring that piece of cartilage to the cover of that lesion where the defect is at. And so pretty good results of that. You have to limit your post-op weight bearing, but the size of the lesion is really limited as well, because you can't take a big piece of cartilage from another spot in the knee because you're going to run out of cartilage. So again, those are smaller lesions. And then after that, if you need bigger lesions, there's a couple other procedures that I do.
Like how big? How big would you say is good to do a plug?
Probably, probably 1 centimeter in diameter, 10 millimeters. After that, then you have to kind of do a couple plugs.
So you take one centimeter plug from somewhere in the knee.
Yeah.
I always tell my patients, this kind of reminds me of like doing a golf course, when they change the hole for the putting.
That's good.
It kind of looks like that, and then that's what it looks like. You got the layers, you see the cartilage and the bone and the subchondral bone, and then you tamp that into the new spot. It's kind of a neat thing.
Yeah.
So in a larger area, or for whatever reason, maybe you don't want to violate the subchondral bone, tell us about the next things that you consider.
So there are some off-the-shelf stuff that cartilage that is being used. I'm not using that quite yet because I don't see, the research isn't proven as well as some other procedures that I use, which would be a Macy procedure.
The one that you use is the Macy.
The Macy, or the osteochondral allograft. So the osteochondral allograft procedure is similar to the OATS procedure as we previously described, but instead of taking that plug from the native knee, the knee that we're working on, we take it from a cadaveric knee or donor tissue. And with those, you can use pretty large plugs. I've done up to 22 millimeters or 2 centimeters. And I've seen other ones that are bigger than that even, because you can take a couple plugs, kind of make it look like a snowball, and put that in there.
So do you take it from the same area on that cadaver? Like, do you get a whole cadaver femur and take it from a similar area so it's got the same contour?
So in order to do that, you have to match it. So we use X-ray and MRI images from the patient. We match it and get that cadaveric or donor bone. It's usually like half of the femur, like a whole femoral condyle, and then in the surgery we take out the lesion that we have the defect. We pull that plug out and then match it with a new donor and then put a plug back in.
That's cool for bigger lesions.
Yeah.
What about the Macy that you were talking about?
So the Macy is the autologous chondrocyte implantation. It used to be called ACI for the autologous chondrocyte implantation, and that's been around for about 40 years or so.
So you're holding on to me. What's the M now?
So the M is the matrix. That just started about 4 years ago, and that's something new. So the matrix, the ACI, which started in Europe, and I think they started doing it in the 80s or early 90s. Again, they've got a lot of good research on that, is where we take a cartilage biopsy, so it's a staged revision. A lot of these cartilage procedures are staged revisions.
2 surgeries.
We do initial surgery, take a look at the cartilage, see what's best for the person, and then if we're going to do an ACI or Macy procedure, we'll take a biopsy of that cartilage. That little piece of cartilage looks like about 2 Tic Tac sizes of piece of cartilage is sent off to a lab, and then it's grown into cartilage cells. Those cartilage cells, again, we used to inject those cartilage cells into it's open surgery, but we'd inject it into the knee underneath this layer we sewed onto the knee or onto the femur. So it took a while. Now it's a little bit easier because those same cells are placed on this little matrix, or kind of like a sheet of tissue, and then that is glued onto that lesion, again during that open procedure, which is the second surgery.
So how long does it take to grow that cartilage in the petri dish?
It takes about 6 weeks to grow it, but we can keep it around for 5 years. So there's no definitive time, like we have to do it at a certain time. As opposed to the fresh frozen allograft, where we get the donor tissue, there is some time constraints on that. We have to find the tissue, and then there's some kind of time constraints on that. But we can keep those cells for up to 5 years, and then if the patient wants to determine a certain time, or if he or she does well from maybe the chondroplasty or microfracture we do, but then develops some symptoms 2 or 3 years later, we can do the surgery then. And then the problem with that procedure, not the problem, but the one issue about that surgery is it is a long recovery.
Because you got to make sure you don't shear that off that you just sewed on.
So it has to grow in, and the cells have to mature, and it just takes a long time for that to mature. It takes about 18 months for full maturity of that, but it's not like we're limiting that patient for 18 months either.
So on the patella, like if you dislocate your patella, and I just had a patient today that I needed to reconstruct their patella because it was dislocating. For those people, if they shear off some cartilage and they're not doing very well, is Macy or similar pretty good for a bigger patellar lesion?
Yes, it is. I mean, initially, sometimes it's hard to...
Patella's the kneecap.
Yeah, and unfortunately, sometimes it's hard to get certain of these surgeries approved, but they are...
with insurance.
With insurance, yeah, but they are... be more receptive to these type of these procedures in this area as well, and in the patellofemoral joint. But that is a possibility, and I've done a few of those as well.
So for somebody who that's for the 2-stage procedures, certainly it's good to use your own cells and things like that. You alluded a little bit to off-the-shelf things that would be ready to go in one stage. I know there are some that use some juvenile cells that you can implant, things like that. What are your hopes with that? What are your concerns with that sort of treatment for cartilage injuries?
Well, a lot of times with these, it's really hard to do really good research, and some of the research is just in the early stages, so we don't have a lot of long-term research on it. So I guess that'd be one concern, as to using that as opposed to the ACI, which again has been around since the 1980s.
Mm-hmm.
So that'd be one concern. We don't know. I guess I don't know much about the viability of those cells, or if they're frozen, do they what their their viability is after that.
Okay. And then we, at DMOS, we have a ortho biologics or regenerative medicine type department. Is there any role for those type of things like bone marrow or platelet-rich plasma or anything for healing of cartilage defects? Do you know? Yeah,
I think there is. And again, the research is all over. It's just because it's so hard. There's so many variables that go into that type of stuff, so it's hard to research. And there is more and more research coming out every day, so there's good potential there.
Real briefly, we'll talk about meniscus another time, but if you do have a meniscus that's gone for some reason, either it was trimmed out surgically or totally pulverized and destroyed in a young person who has an otherwise pretty good knee, can you tell us about meniscus transplant, and do you do those type of surgeries?
I do, and it's a very uncommon procedure. I think the studies show that there's less than 2,000 per year versus like ACLs, there's over 200,000 per year. So it's not a very common procedure, but it's kind of similar to the oats, where we take a donor tissue, and it comes in as the whole meniscus, usually attached to the bone, and you trim. There's different ways to do it, but the way I do is you take a bone plug, and then you make that same like a tray or a trough in the knee that bone plug will fit, and then put that in the knee.
Then you have to sew the meniscus.
And then you have to sew the meniscus in as well.
How many stitches do you have to sew, like back and forth with that sort of thing?
Probably at least 3 or 4.
Mm-hmm. Yeah. Well, certainly a lot of exciting things in sports medicine now.
There are. I mean, I think it's an ever-growing field as far as the different options we have to offer. It's a lot better now than it was even 5 or 10 years ago, just because we're learning new things and just new techniques. There's new ways to do things.
I talked to one of your partners, Paul Butler, and he told me that you're kind of a gentleman farmer now, or a doctor farmer. Is that right?
Well, I did grow up out in the country, and so we were raised animals. My dad grew up on a farm. He was a family medicine doctor, but the farm never left him, and I still enjoy a lot of the country life. So we live on acreage, and we have some chickens and goats. Yeah.
Do you hire out your goats yet to clear brush for people and stuff like that?
No,
You've heard about that though, right?
Yes, and actually, I had almost had someone do that for us because we had so much. It's like a jungle at our place, and it had poison ivy everywhere.
Yeah.
So, and I'm very sensitive to poison ivy, and I just needed to get rid of it. So, we had thought about doing that, but then we ended up just getting 2 goats of our own. We started with 2, and we had a female just give birth to 2 babies this summer.
Oh, nice.
So we're up to 4.
That's awesome. And your kids' ages now are
7 and 10.
Oh, they've got to love that then.
They do.
Well, Dr. Brunkhorst, thank you so much for coming in and talking with us about cartilage injuries, meniscus injuries. I know I learned a lot today, and hopefully our listeners will too.
Thank you very much.
Thanks for listening to Joint Effort, a podcast from Des Moines Orthopaedic Surgeons. If you have questions about this podcast and wish to schedule an appointment with a surgeon, call 515-224-1414 or visit DMOS.com.